We are with Dr. Georgina Lynch from Washington State University, who has some exciting research she's working on when it comes to diagnosing children with autism. And Doctor, I want to see if I get my terminology right. Pupillary light reaction, is that correct?
Pupillary light reflex.
Light reflex. Okay,
Yes.
I was
PLR.
close. But
Yes.
you're using that as a way to diagnose, at least come up with an early diagnosis of autism. And I wanted to first ask you, as I understand it, it's important if we can start intervening when we know a kid might be showing signs of autism in the 18 to 24 months range, but we can't seem to really get a settle on a good diagnosis until about the age of 4. Is that right?
So the most recent data reported by the Centers for Disease Control, yes, has cited that the average age of diagnosis in the United States is 4.5 years old. And our goal is to really identify it much earlier. And that average age of diagnosis really hasn't changed in the last 20 years. So when we think about how early we can identify it, to the very, very well-trained practitioner as early as 12 months. However, that's not in common practice. Our goal would be with our pupillary light reflex measure that it supports screening, and the screening to happen as young as 12 to 18 months.
Why is it important to get that diagnosis and start intervention that early?
It's really important to identify these kids early because we're able to really impact change when the brain is going through a prolific period of development. So in autism spectrum disorder, we know there are strong evidence-based practices that make a difference when those are provided early in development, prior to the age of 5. And so if we're able to identify as early as 18 months or 24 months, we're able to get in during a critical stage of development of speech and language. We're able to work with the family in how to engage their child in social interaction. And so these interventions really have a long-term impact when they're done early at that stage of development. And it can mean the difference between a child obtaining verbal speech or not in some instances as well. So the sooner we intervene, the more optimal the outcome is in terms of treatment.
How and when did you start to notice the pupillary light reflex might be different in kids on the autism spectrum?
So while practicing as a clinician, I'm trained as a speech pathologist. I've worked with kids with autism for many, many years. It was very apparent to me that these children demonstrated a heightened, what we call sympathetic state. Their eyes were dilated even in the presence of very bright light. It was very common for older kids to talk about the light bothering them, or wearing tinted glasses, wearing hats to kind of reduce the glare of light on their eyes. And this stood out to me as a clinician, but only later, really, as a researcher, did I start to explore this concept that cranial nerves in the brainstem that modulate the pupil response could be a good non-invasive way of assessing what's happening in the brainstem in development. And so this is a model of autism that looks at primary process systems of your brain in terms of how you speak, how you hear, how you see. The pupillary light reflex had been studied in autism before. However, it was studied in a slightly different way. What I'm looking at is looking at this regulation between arousal and homeostasis and how we balance that when sensory input changes. So your pupil's response to light is an example of your body's ability to regulate, just as if your fight or flight system kicks in when someone jumps at you and you suddenly freeze up. Your heart may go, but then it may calm down. The pupil reacts the same. In autism, we see that regulation is disrupted.
So you use the terms arousal and homeostasis. Which way are we talking when we're
Yeah.
when we're talking in each of those states?
Yeah, so when we look at the children with autism and when we've conducted these studies, we've tested them in what we call dark adapted conditions. So just like when you go to your eye doctor and they may dim the lights to really look closely at your eye. And what we do is we introduce a light stimulus that just flashes very, very quickly, and the pupil should constrict immediately, and that's demonstrating an appropriate response. Then once that light stimulus is removed and your eyes are adapting back to the environment, which is dark, your eye should dilate so that you can see better in that environment. And that's norepinephrine that's released that causes your eye to do this. What we see in autism is they have a very accelerated constriction and a very slow return to come back to that homeostasis or that pattern of what should be well adapted physical reaction to that setting. So with the children with autism, what we see is they're having this disruption throughout the day. So if you see that this is related to behavior, often it's a sensory behavior. The pupil response is just one indicator, just like your heart rate is just one indicator of your overall health. The PLR is really just a mechanism that we can use to test that autonomic nervous system.
And I want to make sure I just understood you correctly. Are you saying that the way they're behaving could be a reaction to more stimulation than they might desire, or something of that nature?
Partly what I'm referring to is the body's ability to adapt in an environment where things are changing constantly. And so the behavior is not due to the pupil response so much as the pupil response is an indicator that there's disruption in that system. And so we don't see that in kids with typical development. When we provide a pupillary light reflex test to a child who's typically developing, what we see is what's called a really nice curve of a pupillogram that curves just like that. The eye constricts, it redilates, and this happens within a second or so. It's very quick to happen. In kids with ASD, we see that curve very disruptive, and the latency, how long it takes for that eye to change in response to those two conditions, is very different. And so in terms of screening for a neurodevelopmental disorder or some difference in brain development, the PLR serves as a nice mechanism for a medical provider to look at whether our brain development essentially is on track or not. It's simply one measure. It is not a tool that you can diagnose autism with. It simply is looking at the likelihood of disrupted autonomic nervous system reaction, and we see a higher incidence of that in the kids with ASD.
Okay, so not a guaranteed diagnosis. That's a good point to make.
That's right.
But in terms of using this as a tool, as I understand it, it provides more objectivity than a doctor looking at other things. Can you talk about how important that objectivity in the measurement is?
Yes, so our goal with this work is really to bolster the current screening practices that are happening in clinical settings by medical providers and pediatricians. And essentially what current practice dictates is subjective observation of behavior and parent report based on checklists. And what we find is that due to a variety of reasons and social determinants of health, how those checklists are completed and how doctors engage with the families around that subjective analysis really can vary. And so although the screening tools themselves that are published show high sensitivity, in practice, they tend to have poorer outcomes. And so what I mean by that is because of the subjective nature, some children from underserved groups or minority groups tend to be less often identified. And we also see inconsistencies in how kids are being identified. Doctors have told us that within a well-child exam, which is typically only about 20 minutes, they don't have a lot of time to go through the subjective measurement around neurodevelopmental disorders. So what this research does is it offers an objective physical measurement to complement the information that they're gathering from the parent and observing in the child. What it does is it allows them to make a more confident decision in moving toward a recommendation for evaluation. What we often hear from parents is that they were told to wait, or your child is just a late talker, things like this based on that subjective report. Our goal is to help that healthcare provider feel more confident in making the diagnosis that something is different here. And they can make that decision by putting PLR measurements in with other measurements of development. It wouldn't be the sole criteria to make that decision.
Excellent. Now, I'm interested also in hearing about the tool you're using to measure this, because I saw a little video of it. It looks amazing. What can you tell us about this device?
Yeah, so we have two tools that we have used during this research. And the first handheld technology we used is a tool that is out there already in the market as a research standard handheld pupilometer. That tool, however, is really just used in the intensive care unit, where we look at brain development after a stroke or a head injury. And so there's not a lot of information about neurodevelopment or children in terms of development as it relates to these measurements. We used that current gold standard tool to test this idea that we could develop the biometrics that makes sense in terms of neurodevelopment. So we took a handheld tool that is considered a class 1 screening device, and we tested the kids using this device. A whole lot of work had to happen in terms of the statistical analysis that goes into determining how accurate certain parameters of the PLR are in terms of identifying autism. So that's the work we did in the lab. As a result, we have created a prototype that could be used by healthcare providers to provide real-time information. So I test the device, I give the pupillary light reflex test to the child, and I'm given real-time readings of what those biometrics mean. Yes, there is a concern. No, there isn't a concern. Here are the measurements of resting diameter. Here are the measurements of constriction. Here's where this child falls relative to their age. That kind of tool does not exist yet. And that's the work that's coming out of our lab. We've spun this research into a startup company called Aperture Biotechnologies, which is examining how to apply the biometrics developed for autism into a class 1 pupilometer. And that's the next stage of our work, is to test that prototype on younger kids, age 2 to 4.
How would you gauge how the testing of it has gone so far?
So far, we have preliminary data in 2 to 4-year-olds who are diagnosed autism. We have trained clinical teams in capturing PLRs in this population. We're gaining feedback from the clinicians who are doing this, and they're saying it's relatively quick and easy to do, which many people are surprised by that. They think it may be hard to test kids with autism and get the PLR test complete. It's very easy. What we are starting to see is there are age trends, and we're seeing a similar likelihood of discriminative ability of that tool. So what's happening is the children who are in the 2-year-old group are tending to show more accelerated constriction. By the time they get up to about age 4, it starts to slow down, but it's still that complementary cycle, essentially. The constriction and the return to baseline parameters are showing the same difference in this age group as we demonstrated in the paper.
So in other words, that tells you it's working as a tool.
Working. Yeah. Now the goal, in order to really demonstrate its validity and feasibility, which is what the next phase of our work is really about, is to expand this to testing a large number of children in that age range, because that's our goal, is really to see, can we demonstrate this in a way that it will benefit those younger kids. And we are currently on a study where we're looking to partner with clinical sites and academic institutions around collecting the data to increase our numbers. The way in which we demonstrate sensitivity and specificity of medical tests is testing a large number of people. And there are also some statistical means that we can use as well to do that. But right now our goal is to see 300 or so children, and we're doing that with partnerships across the state of Washington and in the United States. I've had families contacting me as a result of some of the highlight of this work, and many are asking to be part of the study from as far as the East Coast to the West Coast. And so we're very excited to see that not only are families interested in this and embracing this, but moreover, the medical community is. And we took some time to assess from pediatricians, do they think this would help their practice? We assessed a group here in Washington State who indicated that it would bolster their confidence in making a decision to refer. And over 85% of the pediatricians we talked to said some form of objective measurement with technology would be embraced in a well-child exam to support the time that they're given with that parent.
So I know you've had a smaller number of children so far. Have we been able to measure it all? How many of them showed the pupillary light reflex that then went on to eventually be diagnosed with autism? Again, it might be too early to even ask that question.
Sure, thank you for the question. We are testing kids who are already diagnosed autism, taking what's called a cross-sectional approach to the research. So we're not waiting to find out if they were diagnosed. We're basing it on children who have received a clinical diagnosis of autism with the current behavioral gold standard tool, the ADOS. And what that means is we're looking at, if you have that diagnosis and you've had the gold standard behavioral evaluation administered to you, what did your PLR look like? Did that PLR predict whether this child fell in the typically developing group or in the autism group? And so we're looking at the PLR measure as a driver for diagnostic outcome in kids who already have been diagnosed. The reason we're taking that approach is because A, it's faster. We don't have to wait 3 to 4 years to find out whether they had autism. And B, because it's a screening tool, not diagnostic, it's important that it also maps onto what the current behavioral evaluation tool is that's being used. So the fact that we were able to have 74% accuracy in terms of sensitivity for 50 children now aged 2 to 4, that is promising in terms of what its potential is as a screening tool. And I think it's important to emphasize for families in particular, this is not a one-all be-all diagnostic measurement at all. What it is it's simply a way to supplement what's currently happening in medical practice when they're visiting with their pediatrician. And although very promising, it still has more work to do. This is a proof of concept study that has been published. The ongoing work with 2 to 4 year olds will take another 12 months for us to complete.
Okay, so not quite ready yet, but I think the big question is, do we have an idea of how long you're looking at before we're able to put this tool to work with pediatricians?
So, as you know, probably in the area of academia and research at the university level, it can take a bit of time. The promising part of the story here is that we're partnering with our medical community and our Office of Commercialization in transferring science into the private sector. So we're translating this into a commercialization path. The research line is focused in that way. What that means is that we're now at the stage where the research has been spun out into a startup company that is able to take the science we've developed and begin to develop technology that can be commercialized. So That path requires a pathway to pre-market submission to the FDA. What that means is that all of the research behind it, as well as the testing of a prototype tool that is currently in development, is submitted before it's marketed. And that submission to the FDA will likely occur in 2023, and it could come to market as early as 2024.
That's amazing. And I'm sure a lot of parents will be, new parents especially, will be very happy to see that. Doctor, did I miss anything that we need to throw in there?
I think I would just add that this kind of research is absolutely a collective effort between our families, our medical community, interdisciplinary researchers. It requires people with expertise in autism, expertise in computer science, biostatistics. It really does, as they say, take a village to bring this kind of innovation in medical practice and autism screening to fruition. So our hope is to really impact that change.
All right, wonderful. Dr. Georgina Lynch with Washington State University. Thanks, doctor. Really appreciate it.
Thank you.